I would like to thank the organizing committee, for inviting me, giving me the opportunity to participate to this workshop. So I have two lectures, one in the morning, and then there will be another one in the afternoon. And the first lecture is about screening or ultrasound marker of Down syndrome in the first and second trimester. So I'll try to spend half an hour with you talking about the subject of ultrasound marker or ultrasound hints for trisomy 21 in the first and second trimester. So let's dive into the subject. First, I have no conflict of interest to disclose. And so what I have to say basically is when you talk about Down syndrome, when you talk about trisomy 21, it's always ethically somehow difficult. It's always a dilemma, of course, because in most cases in Western country, the diagnosis of trisomy 21 will be followed by termination of pregnancy. I usually say it's important to diagnose trisomy 21 whether you are working in a setting where termination of pregnancy is possible or not, because most of these babies will have some degree of placental insufficiency later in gestation and might require earlier delivery, so that they are at higher risk of placental insufficiency, and this is why I think it's important to diagnose. Secondly, I think it's important to know about the soft marker, because even in the era of NIPTS, of the blood test, we still see referrals for suspicion of trisomy 21. For example, you can see here in this referral letter where the physician is probably referring to an echogenic focus, and the patient was referred for further investigations. So you need really to know about, all these markers for trisomy 21 in the first, of course, and in the second trimester. Now let's just go a little bit to the past. Let's go back to the past, because I think I usually say, understanding the past and knowing the past will make you understanding the future in a better way. Having a bigger picture of the whole subject will always help. In the 70s, or maybe, and 60s, 70s, 80s, the way to screen for Down syndrome was to ask the pregnant woman about her age. So if she was above a certain age, 35, usually in most countries, if she was above 35, she was at high risk for having a baby with trisomy 21. And by using this screening strategy of the age, above 35 or below 35, or in some countries, like I remember in East Germany, it was 38. So above 38 and below 38. In some other countries, West Germany, if I remember very well, it was 34. So 34 above and below. And in the UK, it was 35, depending on how much resource the country had and was willing to put in these screening strategies. But anyway, 35 was the age. And by being above 35, you were at higher risk, and you were proposed to have an amniocentesis. And if you were below 35, you were low risk. And of course, in this population, there were also fetuses affected by Down syndrome. By using this strategy, or by applying this strategy, the detection rate for Down syndrome was about 30%. Detection rate for a false positive rate of amniocentesis or a rate of patient you are going to scare, you are going to tell the bad news, was about 5%. So 5% were above 35, and detection rate was 30% in the whole population, of course. Now later, for example, 2000, 2010, 2020, probably more, more patients are above the age of 35. So 15% of the population is above 35. Maybe 20% of your pregnant population is above 35. You will have, if you use age alone, you would have to give them the bad news to all of those patients to detect maybe half of Down syndrome. So detection rate goes up to 50%, but the price you are paying for it is 15% of amniocentesis, or maybe 20%, which is a huge number considering the risk. I mean, there is still a small risk for an amniocentesis. So these are the 70s and the 80s, and nobody does it anymore just to go by the age, which will be really unethical because you are performing too many procedures for a small number of Down syndrome you are going to detect. Now, the 80s, I think the late 80s and the 90s, the whole 90s, were the age of the triple test, of the hormone marker, or of the biochemical marker for Down syndrome: alpha fetoprotein, beta HCG, free estriol, and many, many others. And it was clear that if you do a blood test and you measure this biochemical marker and you combine them in a certain way, you will be able, so the lab was issuing a risk like it is done for NIPTS nowadays. There was a potential to, to screen for Down syndrome. And I remember, and I'm sure everybody remembers the one that, we're already practicing in the 90s, the triple test that was very, very, very popular everywhere. So one way to do it was to offer a triple test and not anymore to go by the age alone. And here the detection rate was about 60%. So you move from age alone, from 30% to 60%, you double the detection rate, and the false positive rate was still maintained at 5%. So it was really good. But here there was no ultrasound marker involved. It was just a blood test and asking for the age. That was the triple test in the 80s and the 90s. And then came the era of the transvaginal ultrasound for the first time. I mean, you could do it transabdominally, but it was much more precise and possible now to look at a fetus in the first trimester. So first trimester goes until 13 plus 6 weeks. So 14 weeks is already second trimester. 13 plus 6, and it was possible in the first trimester to diagnose anomalies, and this was really the start of the first trimester marker, the main marker, which is nuchal translucency. And I will spend a little bit of time talking about it. I know there will be other topics during this workshop about nuchal translucency, but let's dive back in the past, historical approach of the subject. So by the end 80s, beginning 90s, the first, or every big unit was equipped with the transvaginal probe. So you had the abdominal probe and the transvaginal probe, and the transvaginal probe gave you a really better approach to the fetus. And the first paper that was really published about a fetus that was affected by a nuchal edema, by a thickening of the neck region. There was no NT measurement here. So what Rotem saw here from Israel was that basically they saw a thick edema, and then they followed up the case, and the case was, as shown later, in pregnancy affected by trisomy 21. So it was really the first image of a fetus at 11 weeks that was affected by trisomy 21 and suspected on the basis of a nuchal edema or a thick, neck region, edematous neck region. This was followed by the paper of short after, 1 or 2 years later, was published also in the Lancet by two colleagues from Hungary, Csabo and Gellen. Let me take away this bar here so you can see it. So Csabo and Gellen in 90 published the first, really paper where nuchal translucency was measured in a longitudinal plane, like shown on the picture here. This was the picture provided with the article. And there was a measurement that was done here. And if the measurement was above a certain cutoff, there was a high risk of trisomy 21. If it was below a certain cutoff, in their study, they didn't find any fetus affected by trisomy 21. And this is why the cutoff was used for many, many years until the work of Kypros Nicolaides from the UK and the Fetal Medicine Foundation. So what they have done, they performed ultrasound in the first trimester at 11 to 12 weeks. They had 7 fetuses with trisomy 21. All of the 7 had a nuchal translucency above 2.5. It was 3 to 7 millimeter. And then they had a control of 105 fetuses, and all of them, all the normal fetuses had a nuchal translucency below 2.5. And this is something we still use nowadays. So the 2.5, so above 2.5, it's, red flag, alarm. Below 2.5 would be rather reassuring. But of course, it doesn't work that way. You have to measure, and you have to combine with the age, and you have to come up with a certain algorithm, because the nuchal will change along those 3 to 4 weeks, 10 weeks, 11 weeks, 12 weeks, 13 weeks. And you cannot just go by a cutoff, which is now universally known. And that was first recognized, I think, by Kypros Nicolaides from the Fetal Medicine Foundation. And what the first publication together with Rosalind Snyder's late 90s now. You see, the transvaginal probe came in the early 90s, but now we are in the late 90s. What they recognized, or what they observed, is the nuchal translucency will change with the gestational age. Is not a constant structure. Like if you measure it at 10 weeks, it's a bit smaller than if you measure the nuchal translucency at 13 weeks, even in normal babies or fetuses, because it's a small structure, and we are talking about millimeter here. And the thicker the nuchal translucency and the higher the chromosomal rate. For example, if you have a nuchal translucency of 8.5 millimeter, which is very large, then 75% of those fetuses will be affected by a chromosomal abnormality. While if it's just above the cutoff, let's say 2.5, 3.5, just in those ranges, we are not using a cutoff anymore, of course, then the risk for trisomy 21 or any other, chromosome abnormality is, of course, much smaller, 20% just here. But the problem, or, something you have to recognize with the nuchal translucency, that in Down syndrome, the affected cases, they had a nuchal translucency that is sometimes normal, sometimes just above, the range of 2.5, just above 2.5 and below 4.5. So they are just on the upper limit. And this is why it was very, very important, and that was also recognized by Kypros Nicolaides, to really go systematically to measure, to attend the course, to know how to measure, and to combine it, to recertify yourself with the nuchal translucency, and to be able to really master these measurements in the range of 1, 2, 3, 4, 5 millimeter, to not have, to tell to too many patients that there is something abnormal, or to think it's abnormal, why it is not normal. So, of course, there are many publications about how to measure and courses and, how to put your caliber, how to magnify, how to have the right picture. And I usually say it's not always easy nowadays with the BMI of the patient that have increased. But if you want to do it in the right way, you have to really to spend some times, and then you can do your measurements if you are still using it for calculating the risk for Down syndrome. The paper of Kypros Nikolaides, and the observation was followed by many studies, and they all came to the same conclusion. If you use nuchal translucency, your detection rate for Down syndrome is 80%, much better now than the triple test, for a false positive rate of 5%. So you do 5% amniocentesis and you detect almost all fetuses with Down syndrome. These are all the authors that have published all around the world. Probably, I will need 5 or 6 slides to list them all, but many friends here who who worked on the subject, and from many countries, Patrick Rosenberg, Gazurek Wiens from Germany, Peter Schwetzler, who passed away unfortunately, from Austria, and so on and so on. So those who have been in the field for a long time, they know at least to have 1 or 2 or 3 friends who worked intensively in the subject of nuchal translucency. So now this is what was achieved: nuchal translucency and age, 80% detection rate. Now, if you add the biochemical marker, so you go up to 90%. You can combine the whole thing, which is called the combined test. You combine it with the biochemical marker, and then you will detect 10% more. But in the equation, the nuchal translucency was the most important marker. Now, then back to the past again. The integrated test came on the market. Integrated test was, you do a nuchal translucency, and then you do a biochemical measurement in the first trimester. You wait until the second trimester, and then you do another biochemical measurement, and then you combine the whole thing. Had a detection rate for trisomy 21 that was higher than the combined test. And then I think the Fetal Medicine Foundation had to, do something. Integrated test, which was mainly based on biochemistry, was combining several markers together, biochemical marker. Now, in the first trimester, Kypros thought about, and his team, of course, thought about, to combine several ultrasound marker together. And this is why I needed this introduction for the ultrasound marker for trisomy 21. But remember, you can never use them in isolation. So these are markers that you should use in combination with nuchal translucency, maybe biochemistry, maybe, like in combination, and then the algorithm you are using will give you a risk for Down syndrome. Now, these are the marker the Fetal Medicine Foundation looked at. The first publication from Simona Cicero, of course, with the nasal bone, the absent nasal bone in the first trimester. Every patient that is scanned at our institution asks about nasal bone. That's really crazy because, it's every patient knows about the nasal bone, but again, in isolation, it doesn't make any sense. You need to use it as an algorithm. So nasal bone was one marker. Then you had the reverse flow in the ductus venosus, and then you had also the negative R wave, or the tricuspid, the negative R wave in the ductus venosus, and the tricuspid valve, right ventricle tricuspid valve regurgitation above 80 centimeter per second, as shown here, the regurgitation, which was also a sign for Down syndrome, for cardiac insufficiency, for chromosomal abnormalities, especially Down syndrome. So you had the nuchal, you had the nasal bone, you had the absent or reverse flow in the ductus venosus, and you had the tricuspid valve regurgitation. And then by combining all together, you could reach, you can see it here on the slide, how the detection rate was kept better. But again, in the first trimester, it is, you don't take this marker in isolation. You use them as, as part of a screening algorithm. So NT alone, 80%. NT with biochemistry, 90%. NT with biochemistry and nasal bone, ductus venosus, and tricuspid valve regurgitation, you increase to 95%. And here we were at the same performance of the integrated test, with a small difference that the screening was done in the first trimester, and the patient could have, the results and make a choice whether, if it's Down syndrome, to go ahead with pregnancy or to have an early termination. Now, the problem is that when you do this test in the first trimester, so I gave you the 4 marker, NT, nasal bone, ductus venosus, and then tricuspid valve regurgitation. When you do this test, many patients will not accept the fact that there is something wrong, so they will look for another doctor, and who will try to reassure them with a genetic scan, or with using other soft marker and trying to exclude them, to say no, first trimester was wrong, now I can see your fetus is completely normal, and then add an NIPT, and then you are, you avoid an invasive procedure, because many of them do not want to go ahead with an invasive procedure, which is not available, I have to say, everywhere nowadays, because of the low numbers of invasive procedures. So they will go for an NIPTS. They will look for a doctor who will try to reassure them with ultrasound. And these are the marker. So let's start with the anomalies. First, the 2 typical congenital anomalies that are known to be associated with Down syndrome is, of course, I will say, duodenal atresia, classic, esophageal atresia. I've seen many with Down syndrome. And then, of course, the cardiac defects, the atrioventricular septal defect, where you have a ventricular septal defect, an atrial septal defect, and the common valve. And I think these are the 2. But of course, Down syndrome can have many, many phases. And for example, an ascites can be a sign of Down syndrome. Fetal anemia can be a sign of Down syndrome. Many conditions. But let's go by the classical one: duodenal atresia, I would say, and AVSD for the heart. And then there are some soft marker. There are not congenital anomalies, but they will be present with a higher frequency in fetuses with Down syndrome. And again, diving into the past. So this research, what I'm going to present, was done at the same time a little bit as the nuchal translucency research. And I had the impression at the time that in Europe, UK, they were very, towards the first trimester, while in the United States, with Beryl Benacerraf, a radiologist from Boston who sadly passed away, she was really, really the woman behind all the soft marker in the second trimester. So there is no single paper about soft marker in the second trimester where she didn't publish actively. So the first one was the nuchal skin fold thickness, basically the nuchal edema. Remember, this is long time before the first trimester ultrasound. So we already knew that babies with Down syndrome will have a thick nuchal edema. Then there was the mild bilateral pielectasis or hydronephrosis, mild dilatation of the pelvises of the baby at the level of the kidneys. And then we had the echogenic intracranial focus, or the golf ball, or the echogenic ball. The small white dot in the heart is also the group of Beryl Benacerraf. And I think every single soft marker we could think of. She published about it, and they had huge numbers with a big number of sonographer, and they could easily, put these numbers together. But it was always really clear that none of this marker works in isolation. You have to have them associated with other marker to increase the risk. A marker alone by itself doesn't really, increase the risk unless you are not experienced and you don't see the other markers. But when you refer the patient and when they come to us, let's say, if I see, for example, an echogenic focus alone, I will never act on it unless there are other markers. Now, the cutoff for the nuchal edema, okay, or the nuchal skin fold thickness is basically an edematous nuchal skin. So you measure from outside to the first bone you see, because I see it frequently and everybody puts something in different places here. So it's from the outside border to the first bone, and then the cavum septipellucidi should be seen in the front and the cerebellum. So it's basically the level you are going to use to do your cerebellum, and then you measure in this level the nuchal fold thickness. And if it's above 6 millimeter or 6 millimeter or above, at the age between 16 and 23 weeks, then we are dealing with an increased nuchal translucency. That's the principle of it. 6 millimeter or above and 16 to 23 weeks means increased nuchal skin fold, not translucent, of course, and then higher risk for Down syndrome. The second one was the pielectasia. So the cutoff used in most papers is 4 millimeter. 4 millimeter in the antero-posterior pelvic diameter at 16 to 23 weeks. You see here we have 4.3 and 5.1. So both sides are increased, indicates that there is a higher risk for trisomy 21, but again, not in isolation. And this one is the echogenic focus. This one is basically, a small white dot in the heart. It can be on both sides. It can be in the right ventricle. It can be the left ventricle, but mostly seen in the left ventricle with the same echogenicity as the bone above here, okay, as the ribs, for example. You have to have the same echogenicity. Sometimes I turn down a little bit again to have the same thing. And if it's there, it's a higher risk for Down syndrome, but again, not isolated in combination with other soft marker. Now, the late 90s, 2000, there were also other papers, and I'm just citing two from the Charité group. This is the famous right subclavian artery, the aberrant right subclavian artery that is more frequent in babies with Down syndrome. I remember we were scanning every patient coming for an amniocentesis, just, because we were, young fellows and we were doing the biometry before. So, and there was an interest to try to see if this baby that's going to be diagnosed with Down syndrome had any marker that are not known in the literature. And I remember when Rabbi Shawi was scanning this patient, so he realized that the subclavian artery on the right side was not originating from, the proximal part of the aorta. We'll show you a drawing in a moment, but from the distal part of the aorta, going around the trachea and the esophagus, and then going to the right. Basically, it was the right subclavian artery, which is aberrant. It's called ARSA, aberrant right subclavian artery. And there were some publications, but there was nothing about ultrasound in pathology where this was observed in, post-mortem Down syndrome with a higher frequency and less in the normal population. And we all know it's a marker for Down syndrome, of course, not isolated, but when you see it, you have to be careful. So this is usually seen at the 3-vessel view here, okay? So you have the three-vessel trachea view. Normally, so it forms like a V shape. Normally, the right subclavian arteries should originate from this part of the V, basically the proximal to the heart, from the part, not from the tip of the V, not where the two vessels come together. If it's originate where the two vessels come together, like here, it is called aberrant right subclavian artery, and then it is high risk for trisomy 21. So can look at the picture, V shape, tip of the heart here at the lower part, the aberrant one. The normal one will come from the upper branch of the V, basically proximal part of the aorta, and then goes to the right side. And then what we observed as well, here a publication also, you see, this is mid-2000, after the millennium, where we, this was, some work we have done at the Charité, where we looked at and we realized that fetuses with Down syndrome, if you use 3D maximum mode, you can really, look at the ribs, count the ribs, and we were comparing our findings with the, for example, a CT reconstruction in this fetus. So we had somebody from the radiology department, Patrick Rogala. He was really an artist in CT scans. This is a fetus at 16 weeks where you can see the bones and you can count the bones or the ribs on this side, and you see that there is an absent 12 rib. And the 11 ones was a bit shorter, and it was confirmed. And then we realized that Down syndrome newborns, they were screened in the 50s and 60s by doing an X-ray and counting the ribs. So it was a known marker for them, but we will use it, but not, of course, in a screening setting, just as an add-on to say, to the patient that is scared now that the baby is affected by Down syndrome, to tell her, no, the ribs are all there. It's really a reassuring sign. But let's move on to the most important one, in my opinion, which is the nasal bone, because fetuses with Down syndrome, and you see here Beryl Benasseraf again publishing about the nasal bone. Fetuses with Down syndrome, they tend to have either a shorter or an absent nasal bone, as shown in the first trimester by Simona Cicero and Kypros Nicolaides, that was published in Lancet. So normal nasal bone can be absent, frequent, or small frequent. Okay, so that's the first message you have to understand. So the nasal bone tend to be smaller, okay, but it can be normal. And also in fetuses with Down syndrome, the prenasal edema, as shown here on the slide, you see the prenasal edema, tend to be bigger. So they have shorter nasal bone, bigger prenasal edema. And this was shown by a publication from Nicola Persico, who is from Italy, was a fellow with Kypros Nicolaides, and went back to Italy. And we met at many conferences. So he showed that the prenasal edema is bigger in Down syndrome. And then we have the famous or really important paper of Katia Bilardo and her group. And she was the senior author in this publication. And what they have done is they collected 3D volumes of the face, and they had the idea to take the nasal bone measurement and to take the prenasal edema measurement and do a ratio between prenasal edema to nasal bone. So basically, if the prenasal edema is bigger than the nasal bone, if the ratio is above 1, it's a sign of trisomy 21. If the ratio is below 1 or below 0.8, then it's a good sign. So let me repeat it, so there is no confusion. So if the ratio if the ratio is below 0.8. If below 0.8 means you have a thin nasal edema and a big nasal bone, then it's good. If the ratio is above 0.8, means you have a thick nasal edema and a short nasal bone, then it's an alarming sign. It's always good to have a nasal bone that is longer than the prenasal edema. The nasal bone is longer, the nasal bone length is longer than the prenasal edema. Thin prenasal edema, good. Long nasal bone, good. Okay, so I hope I've done it, repeat it many times to be understood. And what they showed in this publication, and I was really, I thought, oh, that's really an important message, because what they showed is that all babies with an abnormal prenasal edema to nasal bone ratio, which was basically indicating that the prenasal edema was thick and the nasal bone was short, had Down syndrome. So in other words, there was no single case with Down syndrome who had the normal relationship, basically long nasal bone and thin prenasal edema. And I really, I think since I read the paper and since I understood what they were trying to say, I have never came through personally, I think it's more than 200 Down syndrome by now, never came through a baby with Down syndrome with a complete normal face where the prenasal edema is super thin and the nasal bone is long. And all the babies I've seen with Down syndrome, they had this ratio. And I'm saying this because I use this sign really frequently to reassure the patient and to tell her, look, the face looks absolutely normal. In our experience, it cannot be Down syndrome, but to be more reassurance, of course, you can do the invasive testing, you can do NIPTS, but this is already reassuring when a patient comes after all these soft marker we talked about have been seen and wants more reassurance. So a good sign is when the prenasal edema is thinner than the nasal bone. That's always really, really reassuring. Important is you have to scan the nasal bone at an angle of 90 degrees approximately. I will even put it a bit more, like I will say with an angle of maybe 20 degrees. I will just slide a little bit the transducer, but this is now going in too much details. Whether I look at old pictures or new pictures, the nasal bone was always very short in Down syndrome and the prenasal edema was always thicker than the nasal bone. And as I said, I have never seen a baby with a face like this, with a very thin prenasal edema and a very long nasal bone who was affected by Down syndrome. That is, for me, almost an exclusion criteria, and I'm happy to discuss it with the chair at the end of the session. Thank you very much for the attention for the first lecture. Thank you very much. Yes. Hello again, everybody. I think we will move to the next lecture without further delay. So it's my pleasure to introduce Professor or Dr. Vivek Krishan from Kochi in India, who is the head of the fetal medicine department there. And he will be talking about pretty the same thing we were discussing now for trisomy 21, but for trisomy 13 and 18, I always thought, or under the impression that they can be in these fetuses anything, but I'm sure there are specific signs for trisomy 18 and specific signs for trisomy 13. And to you, Dr. Krishan, to present the lecture. Thank you.